Hey, good morning, everyone, and welcome to the, well, man. Hey, good morning, everyone, and welcome to the UroPatient podcast. I'm your host, Vic Senese. Glad to have you here today. If you're watching us live, you're watching us on YouTube, LinkedIn, Facebook Live, X, or Kick. Welcome to the show. We come there all the time. Hey, for those YouTubers out there, be sure to hit that like button. It really helps our numbers go up better. So numbers are good. This is your first time joining us, go to UroPatient.com, the best place to catch all of our past episodes, learn more about the website, and find all sorts of stuff. We got a bunch of past episodes up there for you, so be sure to check those out. Also, we have a whole bunch of these nice, helpful handouts on our website. Download them, bring them to your doctor's appointment. They're perfect for that. So this week, I'm joined by one of our other podcasts. Dr. Jeff talks about sex and intimacy. I have the host of that, Dr. Jeff, joining us. His website's drjeffsextalk.com. It's every Tuesday at 7 p.m. So let me tell you a little bit about Dr. Jeff. He's a board-certified advanced practice urology clinical nurse specialist, nationally recognized researcher, and author based in Chicago. With over 30 years of experience caring for individuals with sexual dysfunction, Dr. Albaugh has dedicated his career to improving the sexual and emotional well-being of patients facing urologic and pelvic health challenges. He is the host of Dr. Jeff Talks About Sex and Intimacy, where he brings thoughtful, evidence-based conversations to light, helping individuals and couples navigate complex topics with compassion, honesty, and hope. So, hey, I got some questions I did want to talk to you about, Jeff. This one I kind of heard quite a bit from patients in the past. After they had their prostate removed, they're concerned, am I still able to climax? And I know you talked a little bit about some of the physiology and stuff behind it, but maybe you can go into that a little deeper about whether you can or can't and how it works without a prostate.
Yes, and that's a great question. That's why I tried to address it, because men are talking about this and it's not often addressed because it's overshadowed by erectile dysfunction. But also men in my study and other studies talk about, can you climax? Climax is the sensation that you feel when you orgasm. So yes, most men, the majority, can climax afterwards. You saw in the one study about a little less than a quarter had difficulty climaxing at all afterwards, and that may resolve over time too even. So most men can get the climax sensation. Is the sensation the same? That's the important thing that I tried to highlight. And so some men say it's diminished or different. Probably that is the most common one we found. I know that's what we found.
You think that's a psychological effect, that nothing's coming out of their penis? Because I hear the same thing from men that have had, like, prostate surgery for blockage and end up with retrograde ejaculation where it goes back into the bladder instead.
I think it has a psychological component, absolutely, for some men. But I do think if you can't climax, that's going to be a physiologic thing in those men in particular. And also, I will tell you, Vic, that, and again, how do you compare before and after? Because your memory of before is not absolutely on the money, right? But the thing is I do think that men will say, it's different. It feels different. It's upsetting. In my group, my prostate cancer group that I run on the third Thursday of every month at Gilda's Club and part of Zero, men talk about that and are frustrated by it. So I do think there's, for some men, a physiologic component. And I think for even more men, there's that psychological component. Nothing's coming out. Some men are bothered by that. Some men are like, I had one partner in man say, hey, there's no mess. That doesn't bother me at all. That's fine. So everybody
making lemonade from lemons, right?
Right. Everybody experiences it differently. But I think it's such a good question, because the bottom line is climacturia is not very common, but it can occur after prostatectomy. But most men still are able to enjoy climax or orgasm sensations, even though they don't ejaculate after prostate cancer surgery. I think that's the most important message to know about a climax after prostate cancer surgery.
And I like the fact you have some of the, research that you've gotten from your own patients and your support clubs, because, a lot of times we just kind of blow it off and say, no, you're still climaxing. It should be the same. You know, and it kind of brings me to this next one we were talking a little bit about is penis shrinkage. I mean, I could tell you that patients came in complaining for years about their penis was shrinking, and we kind of said, not really, you know, that's just all in your mind. And as you said, you know, if you're not getting erections all the time, you can have, you know, real measurable differences in penis. I actually did a talk a couple weeks ago about penis shrinkage. So it's real. It happens. But do you have any good strategies on what they should do to prevent that from happening?
That's what's so interesting with this topic and the one we were just talking about with climacturia is, you know, we kind of poo-poo it and say, oh, you're fine. And you know as well as I do, Vic, even some of our men who just have erectile dysfunction, not after surgery, are like, over time, they say, it seems like my penis is shrunk. It seems like it's not as large as it was before. Is that psychological or physiologic? Of course, like all of this stuff with sexual function, it's probably a combination of both. So I think the most important thing to understand is that we have documented and said, you are not crazy. Penile shrinkage is real. And even if it is more of a psychological effect you're experiencing and it's real to you, and that's important. But physiologically, what can we do about it? Exactly what we talked about, the strategies. If you get that penis moving with pills, if it doesn't move with pills, you're not getting any help with penile shrinkage on that. But if you get the penis moving from taking the pills regularly and getting and working with your penis to get it moving a little bit more. So what does that mean? I talked about it a little bit before, but so you think sexual thoughts, you stimulate the penis when you have privacy in the bathroom or shower. A lot of men do it in the shower, and then you're not trying to climax, because once you climax, nothing's going to happen after that because it's not going to move anymore. But you get it to move however much it does, and then you let it settle down while you go on with your shower. You get it to move again. You let it settle down while you go on with your shower. You try to get it to move. Remember, it used to move about 5 to 10 times a night. You were hard about 2 hours out of every 24 hours. So if you can get it to move a couple times, you're mimicking. So we call that daily stimulation of the penis to try to get it to move. You're encouraging blood flow and muscle activity.
That's the body's natural way of keeping restoration, keeping the penis ready for action.
Yep. From the pills, even without the pill, every day you're trying to get it to move some, especially if it's not moving at night. If it starts moving well and it's moving at night, you don't have to do anything, just like you didn't have to do before you had erectile dysfunction, because it's functioning. But if it's not, get it to move. So regular movement activity with and without the pills. And then if it's not doing enough, do some stretching. Studies showed that doing stretching carefully, methodically, with the vacuum pump may help as well with penile shrinkage. There's a couple studies out there. Dr. Kohler, who's going to be on our podcast, did one of those studies, but you can use the vacuum pump for stretching as well. So yes, that's another strategy. Some people use injections to get regular erections. If you're using any of these treatments to get muscle and blood flow activity as prescribed, as taught, these are things that can help not only with hopefully recovery of erectile function, but also potentially with penile shrinkage.
The other thing I was going to ask, so patients have always kind of wondered, when should I start taking things like Viagra? You know, if you had the surgery or catheter to be removed, how soon do you recommend they get going on things like Viagra or vacuum pumps or any of these in treatments?
Excellent question. And everybody wants to know that answer. And we don't know definitively, but I will tell you, if you have any slight issues, even like your erections don't get as hard as they used to, what strategy a lot of people use is before you even go to surgery, they start tuning you up with a little, with some medication. It may be a low dose daily of that medication, but taking the medicine before you even go to surgery or before you start radiation, and then stopping the day you go to surgery. You don't need to take it the day you go to surgery until the catheter is removed, and then restarting that medication. You do need your provider's supervision with this, but most strategies say if you can or need to start before surgery, stop the day of surgery, restart when the catheter comes out. But if you're having trouble, if you're struggling, or the erections are uncomfortable or painful because of the surgery, wait. let yourself heal a little. There's no definitive thing that says you have to start at the day the catheter comes out, but you can, most men can and do start at the day the catheter comes out. And a lot of studies say that that is one way to do it. If you didn't start it before surgery, don't worry about that. Don't be upset about that. Start it when the catheter comes out, mostly using regular daily doses of that medication.
Jeff, do you like to do the shim study ahead of time for patients? I know that a lot of men underreport some of the issues they're having with erections even before the surgery. Then they come out, oh, well, now I'm having trouble with erections. It's just from the surgery. But I think things like the shim have shown that there were some pre-existing things.
So the shim is the sexual health inventory for men, Vic, and it's a great point. And I love doing it before, after, at all those junctures, because now we can quantify the shim is 5 questions, and it gets at your erectile function. Mm-hmm. So we can quantify it. So even though you may be like, it's not that different, now we find your shim score went from 14 to 20 or 14 to 18. We can see there's a difference, and we can tell you and show you and quantify. No, you're not where you want to be, but it's better. So right. I really like using it at the different junctures. We usually used it before because we want a baseline. Before you go to surgery, where is it at? After surgery, and then at 3, 6, 9, 12 months, 2 years, all those places you can use it. You can go online and get it. It's the Sexual Health Inventory for Men. It's a 5-question erectile function questionnaire. It's a great questionnaire.
When we talk about pills like Viagra, and you'd mentioned several others, do you have one you prefer over another, or pretty much whichever one you think you're going to want to take? Or
again, you can tell Vic has done a lot of this work like I have with patients, because these are phenomenal questions. Every single one of those pills works the same way. They're PDE5 inhibitors. They inhibit the chemical in your penis that inhibits your erections. Think of it like math with a double negative. If we inhibit the inhibitor of the chemicals that make you hard in your penis, now we have those chemicals that make you hard in your penis in abundance. They're not being inhibited, so that when you get excited, and only when you get excited, you could get harder. All the pills do that exact same thing. The reason sildenafil is the #1 Viagra, it's also called the #1 medicine still prescribed, is just because nothing ever worked any better, but the other things don't work any worse, because they work the same way. So all of them have pretty equal efficacy and safety. So I don't necessarily say definitively use this one over that one. Some people, the reason tadalafil Cialis is #2 is because it lingers longer. It lingers up to 36 hours. So if you take
you can take that 5 milligram dose daily. And just
you can take it every day, and then it's going to give you a steady, not a complete steady state, but 5 to 10. Yeah, 5 to 10 milligrams will be in there, because you took 5 one day and 5 the next, and it lasts 36 hours. So, and some people take a booster dose when they're trying to have sex of an extra 10, because they need 20 when they're trying to have sex as well. Mm-hmm. Work with your prescriber and see what works for you. But some people like the tadalafil because it lingers longer and it overlaps because of that. Whereas if you wanted more of a steady state of sildenafil, because it lasts about 8 hours, that would be like an overdose, because you'd need to take it 3 times a day, and you're not supposed to exceed 100 milligrams in 24 hours. And so there's lots of things to think about with your prescriber. But in general, the 2 most prescribed things for penile rehab are sildenafil, Viagra, and tadalafil Cialis. Vardenafil can be used as well, but those are the most commonly used ones. And in the studies, that's the ones that were mainly used.
I think the best thing too is they're all generic now. And, they used to be, I don't know, $10, $20 a pill when they were trade name, and now they're pennies a pill.
Absolutely. And that's the thing. So with GoodRx, or sometimes like some pharmacies have their own equally good discount programs, but you can get these medicines generic prescription. You always do this with a prescription under a provider, but you can get generic versions of them for like $1 or less a pill, which is amazing compared to 50, $100 a pill sometimes.
It was nuts.
It was crazy.
Now, we have also talked about the vacuum device, and another, I think, great tool for, especially for penile rehab, can be used for intercourse. What's your recommendation on how often they should start using the vacuum device after they're given the clearance from surgery?
And the thing about this is we usually say with the vacuum device, you want to allow a little bit of healing there. Some people wait 30 days. Some studies showed afterwards to start it. Work with your provider to see what they recommend. Some people will start it 2 weeks to 30 days. In general, we usually start the pills when the catheter comes out. 30 days after surgery, begin using the vacuum pump for stretching. But study after study shows intervening early like that is better than waiting 3 months or 6 months to see what happens. So when it comes to penile rehab, work with your provider, but we usually start pills when the catheter comes out. Again, if you took them before, start them again when the catheter comes out. If you never took them, start low, go slow, take them after the catheter comes out, and then add the vacuum pump. Usually you give yourself a month of healing. Some people say it can be a little sooner, but most studies say 30 days of healing, and then start with the vacuum pump and use that each day. I recommend every day, once a day.
And that can be without the rubber bands, just to cause the erection. That's all you need.
You do not need the constriction ring or any of that when you're rehabbing. The only thing you need, the constriction ring is for sex. It's not for rehab. All you're doing is stretching. So you use the vacuum pump with the water-soluble lubricant. That's all you need. And you do it every day. And usually we have patients do 5 to 10 of those penis push-ups, those painless, even lifted off erections inside the pump, holding them each for a minute or two. Now, there's still limited research that says that's the absolute way to do it. So if you hold it for 2 to 4 minutes or something, that's okay too. Or if you hold it for 30 seconds to a minute, nothing says definitively what's exactly right. But we usually do 5 to 10 penis push-ups a day, holding them each a minute or two for stretching. And so if you're willing to do that and okay with doing that, and if you could take the pill an hour beforehand, even better, to see what's happening. But always put as much as you can get in the vacuum pump, whether it's with the pill or not. If you get a 20, 30% erection, a 40 or 50, or even a 70% erection, you put it in there. You're not trying to overstretch, but you're trying to get to an erection that's painless, even, and lifted off.
Yeah. Now, a lot of patients don't know this, but back when this came out, it was through the offices, it was $500, $600, $700 for vacuum pump. It's over the counter device. You can pick it up anywhere. Do you have a best place that you like to tell patients? I mean, the cost of vacuum pumps can be anywhere from $50 to $100 now.
Yes. So there's a lot of medical suppliers. There was a diabetic website that had a pretty good price on one of them I liked a lot. Amazon has medical grade pumps. So once you figure out what you want, a good medical grade pump, and I talked about several. I don't endorse one in particular. A good medical grade pump is a good medical grade pump. And you don't necessarily need a battery operated unless you have problems with your hands or carpal tunnel or some restrictions. It's very easy to pump and control it by pumping with your hand. And so mostly I used manual devices with men because the vacuum pump, whether it's battery or manual, they both work. So a good medical grade pump, and you can get it off Amazon. Search out there, see who's got a reasonable price. But medical suppliers, typically I find they cost in the neighborhood of about $100 average for a good pump. Sometimes you can get them for like $40, $50, $60, but typically right around the ballpark of $100. A lot of them have free shipping. You can get an excellent pump. I used quite a bit, 3 pumps in my practice, but there's other good pumps too, but I used the Post-Evac manual device. I used the Encore, and I used the Erecade. Those were the 3 main ones I used, but sometimes we used Augusta Medical had another good one. There's really good.
The thing is, even the name brand ones have come down to reasonable prices. If you're in the $100 zone, you're probably getting a medical grade. You keep saying medical grade pump. What people don't understand is people were selling these pumps and they were using devices that were used to check the suction on a car's vacuum and you could just get unheard of pressures in there and really cause black and blue penises.
Yeah.
So make sure spend about $100, get one that's probably a medical grade.
For sure. You really don't want to use something dangerous like that on your penis. But there's so many good medical grade pumps out there for sure. So yeah, and your provider can maybe recommend several different brands. There's really good brands.
Yeah.
Did you use those similar brands or something different?
I did. Amazon now is pretty much our go-to. I mean, they carry everything. It's hard to avoid it. We did talk about this question with the injections. You did talk about some of the research that you had on, do they hurt? And that's, I think patients have always been needle phobic, afraid of getting, a needle injection. But, I've given this to patients, for the past 40 years, and that almost never had a patient, once they stick themselves, complain that they actually even hardly felt it because it's such a small needle. And your research would kind of stick with that. Does not hurt, right?
Absolutely. The needle stick itself is not a painful thing. And so, like I said, 40% of our men said 0. If you want me to rate it 0 to 10, which I was like, wow, that's almost half. And then of the men who rated any pain, our average pain rating was 1. Other studies show 2 out of 10. Those are very low pain ratings, and it's over quickly. It's super fine. It's super small. The pain really comes in as the prostaglandin kicks in, and that's where you can get a throbby, headachy feeling in the penis from the drug. And about a third of patients get that.
Yeah. I'm going to knock it off with one last question, because this is something you've talked about, and I think it's probably important for patients that are having problems with erections. Is there are other ways out there, and can you discuss a little bit what outer course is?
Definitely. It's a great question. And we did a whole podcast on it with Dr. Kellogg did a podcast with me on it, but non-penetrative sex, manual stimulation, oral stimulation, vibratory stimulation, rubbing genitals together. Penetrative sex is intercourse, penetrating a partner. Usually that means penetrating the partner with your penis. So you have to have a hard enough penis, but non-penetrative sex or outer course is everything else. Manual stimulation of the clitoris, oral stimulation of the clitoris, vibration of the clitoris, rubbing the penis and clitoris together, manual stimulation of the penis, oral stimulation, vibrate, all those things, and exploring other erogenous zones of the body as well. So non-penetrative, we call it outer course. And so yes, that is something that people who've had erectile dysfunction usually discover because they want to have sex and they want to be sexual with a partner, and they aren't hard enough for penetrative sex. Penetration is just one way. It's not the only way.
Yeah. Well, Jeff, it's been really great having you on the show today. It's a lot of great information for patients. Most important thing out there is don't forget there's options. Don't just give up. And catch us again next week for more on UroPatient.com.